I am not myself an academic, although I do, as Simone mentioned, serve in a number of capacities for a number of institutes. And I have been teaching for 14 or 15 years now at the U of T. But I am a practical, hands-on problem solver, and I'm an active investor in the digital health space. And I have, during the pandemic, played several roles as a rear echelon commentator, trying to do my best to support the amazing frontline healthcare providers who've been out there delivering care. I've done 3 projects for various parts of the federal government, one on long-term care very early in the pandemic, one on pandemic resiliency towards the end, and the one that I'm going to talk about today, which was on virtual care. That pandemic, was done during wave 3 of the pandemic, and the report was published by Health Canada in August. During that preparation of that report, I worked with an excellent team and prepared the report based on about 100 interviews, many of them with frontline providers. The purpose of the report was to give a summary of where virtual care was and to talk about its future. You can grab the report at several points from QR codes scattered throughout this presentation. As we all know, in the first wave of the pandemic, we switched very quickly to virtual care. In Ontario, we passed 75% of all visits virtual by about April, May. Though that flip happened because the provinces all moved quickly across Canada to reestablish and open codes, K codes in Ontario and similar codes elsewhere across the country. That happened very quickly and created a sudden switch, not just to video, but more importantly to telephone. There are various ways to view what happened, and during interviews I heard at least 4 different perspectives. Some people saw it as an emergency life raft, some people saw it as a low rules experimental environment, some people saw it as a stress test of our existing systems, and some people saw it as a shift to consumer-oriented healthcare. None of those 4 perspectives is absolutely right, and all of them have some elements of truth. And what we do in the report is to talk about how those different perspectives will influence what you saw, what you see, what you expect in the future. At the end of the report, we delivered 43 recommendations. And again, the report is available if you snap the QR code in the bottom left corner. And we talked about 8 major categories for those 43 individual recommendations. What I'm going to do in today's presentation, I'm going to orient you to the report, and then I'm going to pick 4 of those, not the 2 that Michael and Vanessa are talking about, and I'm going to go deeper into those 4. The overarching principle of the report was that care is care, that virtual care is no longer some adjunct therapy. It's a core part of the publicly funded health system. And you can argue whether that will end up being 30% of the health system or 60% of the health system, but it's probably somewhere in that range. For that to happen, we need to modernize licensure. We need to have usable digital information, and we need to have that soon. One of the things that we saw very clearly, and that I think we've continued to see in later waves, is that usable digital information is actually a patient safety issue, which is important, meaning that not only is it a convenience issue around getting it, but we're actually putting patients' lives at risk when we don't have usable information systems. Couple of principles. One, that we need to have modality-based, modality-neutral reimbursement systems. I'll come back to that. But we need to be paying for outcomes when we're buying technology. That we need to think about the old and the new and managing from a what I call a double clinical baseline. Again, I'll come back to that. The importance of the telephone was truly striking by wave 3 of the pandemic. In Canada and elsewhere, when people said virtual care before the pandemic, they often used it as a synonym for video. That was never correct, but in the pandemic, it became clear that telephone was important, and particularly important if we wanted to have good access for people. A lot of people need talk and text and don't have bandwidth. And then finally, in closing, and we talk about this at some length in the report, that the way to judge what we want to do going forward in virtual care is based on user experience and clinician experience. To put it in more highfalutin terms, we want to look at those two elements of the quadruple aim that often get underused, which is patient access, user experience, and clinician experience. We have to build those in along with quality and cost, which frankly have always received good attention. Now I've got about 8 more minutes left. And so what I'm going to do in those 8 minutes is go through 4 of these 5. I'm going to leave primary care. It'll be in the appendix of my report distributed, but I know Michael's going to talk about that. So I'm going to focus on money, change management, mandating digital information, and enforcing interoperability. And each of these, my perspective on each of these has changed somewhat from the phase 3 report. Let me frame that up just a little bit, because when we were writing at the end of phase 3, we believed, obviously incorrectly, that that was going to be the last major wave. And I think, having done a report at the end of phase 4, I can tell you that I at least believed that that was also going to be the last major wave. At the end of phase 5, I no longer believe that. The end of wave 5, I no longer believe that. I think that what we're in is a world in which we will see changing costs of physical contact. Wendy Levinson and Sasha Bacha wrote about this in the New England Journal of Medicine, I believe, and talked about costs of physical contact and how those are essentially providing a user fee that blocks barrier, or that creates a barrier to access for people. We need to think about what those user fees look like and understand that infection control causes those to rise during heightened levels of viral activity for COVID, but frankly for other diseases as well. And that as those costs go up, the barriers for people go up with them, and we need to think about that. That means that what is clinically appropriate in some settings may change based on provider judgment and based on patient convenience. And we need to set up a modality neutral fee schedule that allows providers and their patients to move amongst those. Now, that's a principle, that's a hard to attain goal. Saying something is modality neutral doesn't mean that we just pay the same for everything, because some things, frankly, take less time to do. Returning email takes less time, generally speaking, than phone calls, which generally speaking take less time than video. Video and in person actually tend to be fairly close to one another in terms of effort, and that has some implications. To do that, that means things like more bundled payments. That means don't micromanage. That means move away from fee-for-service where possible. It also means we need to pay for asynchronous care and that we need to incorporate accessible services in. Let me switch to change management. Most change management theories in use today were written about the year that I was born, including the one that I have pictured here. Most of the ones that I've used during my career are about as old as I am. They usually talk about innovators, early adopters, early majority, late majority, laggards. And that change management theory went out the window with virtual care during COVID. Why did it go out of the window? Because instead of a stable climb, we went discontinuously to 75% and then came back down and then bounced back up. And that bouncing, as I said earlier, is going to continue based on the costs of physical contact. When costs of physical contact rise, the need for virtual care will rise as well. That's appropriate. Again, let me say, costs of physical contact always existed. Our friends at Canada Health Infoway have actually estimated that the cost of physical contact pre-COVID were on the order of $100 a visit in terms of lost income, babysitting, parking, etc. That user fee in time goes up and down as infection goes up and down, and that means that we have to have a different way of thinking about how we manage change, but also from a change management point of view, as we've seen with the college letter that went out around, hey, you guys stop all that virtual only stuff, right? Approaching from the top has a different set of change management challenges. One of those change management challenges I call the double baseline. And the idea of the double baseline is that if you were running up, and I don't run these things, so I get myself in trouble here pretty easily. But when you run clinical trials before COVID, you took the existing set of practice, you used that as a baseline, you said, is this going to improve care? Now you've got two baselines. You've got your 2019 pre-COVID baseline, but guess what? You also have a 2021 baseline, because in many, many, many specialties, care changed dramatically during 20 and 21. And let's make no mistake, there are a bunch of those specialties that aren't going back. Now, I've just got a couple of examples here. There are a whole bunch more in the report that you can go through, and there are a bunch of different personas, because this also pays out on the patient access side. Inflammatory bowel disease for pediatrics, mental health, pre and post-surgical bundles, congestive heart failure and endocrinology titration. These are all examples of things that it turns out we can do pretty well virtually. In fact, arguably in several cases, we might even say better virtually. So all I'm saying with the double baseline is you got to do 2019, you got to do 2021, you got to think through how you're going to do that, use some common sense clinical judgment as we move forward. That's happening. I was delighted by the leaked copy of the PSA that I saw, that some of that seems to have been picked up in the fee negotiations. That's very good news. We saw that this week with glucose monitoring for type 1 diabetes being added. Third one, major systems failed. Major systems failed. There's a study that hasn't been released yet that the ministry did on fax machines. Rumor has it that in our peak month, our fax failure in Ontario was over 25%. That's not acceptable. Labs are ready, prescription pharmacies are ready. It's time to push this over. It's time to regulate. It's time to say you may not do this without having, sorry, my power failed, without having things ready and without having basic health data in a usable digital format. That requires a regulatory response. We have not done a regulatory response. We've only ever done incentives, and we need to stop doing that. And we need to start pushing people over. In the report, we said April 2023. The point is a date certain. Final point, interoperability in an oligopolistic market. We need a regulatory environment that's modeled on the Competition Bureau in healthcare, and we need that to be existing now. And Simone, I'm going to pass it back to you there, and thank you very much, and I look forward to the discussion.
Thank you so much. Great presentation, Will, and we're already getting questions coming in, but we're going to hold off until everybody's presented and we'll have a group discussion. So now I'd like to invite Vanessa Gruben to deliver her presentation.
Thanks very much, Simone, and thank you for your comments, Will. It's an absolute pleasure to be here on a panel with Will and Michael. So today, what I'm going to be focusing on are some of the professional and regulatory issues that arise with respect to this shift to virtual care. As Will has mentioned, and I'm sure as Michael is going to discuss, there are tremendous advantages and benefits to virtual care. Virtual care has resulted in many Canadians accessing care more quickly, and for many patients, this care has proven to be more convenient. However, virtual care also poses new challenges for healthcare professionals and patients. And so what I'd like to do today is address a few of those issues and describe how best to address them to ensure that patients really are receiving high quality virtual healthcare. So I'm going to start with a brief discussion of licensure. Although there have been some discussions about creating a pan-Canadian license for healthcare professionals, this hasn't yet happened. So I'm going to talk a little bit about that. And then I would like to discuss a few of the issues that have arisen in clinical practice. And again, sort of how best to approach those from a regulatory perspective. So in terms of the definition of virtual healthcare, this is a great definition from the Canadian Medical Association, and it's important when we're thinking about virtual care, being clear on the scope of what this is and how it's distinct from digital health. So again, here as Will has highlighted, what we're focused on is the interaction between patients and members of their circle of care occurring remotely, and of course the aim here is facilitating and maximizing the quality and effectiveness of their care. There have been a number of organizations who have really led the charge in terms of thinking about some of these issues, and indeed many of them were thinking about and reflecting on how to ensure we have top-notch quality virtual care prior to COVID. Of course, as Will has highlighted, the explosion of virtual care during the pandemic has really accelerated the engagement of these organizations and many researchers. So this is, for example, one report that was done just prior to the pandemic, but we're seeing lots of engagement from multiple organizations. So let me begin with licensure. This is something that it's not the first time that the topic of a pan-Canadian license has arisen, but really prior to the explosion of virtual care, cross-provincial licensure was less of an issue given the physical restrictions that existed for most healthcare practitioners. Practitioners almost always treated patients in their offices, clinics, and hospitals in the province in which they were licensed. And of course, virtual care represents an important shift in that model for some practitioners. Virtual care, as we know, has now made it possible for healthcare professionals to provide healthcare services across the country and possibly across national borders as well, but we're not going to get into that today. So practicing across provincial borders is certainly challenging from a regulatory perspective. As I mentioned, there is no pan-Canadian license for a healthcare provider in Canada. Each province instead has its own licensing body, and each licensing body has its own set of rules, which has really resulted in a patchwork of different requirements across the country. So what that means is that healthcare professionals have to ensure that they're complying with the requirements where they're licensed, sometimes referred to as their home jurisdiction, as well as the requirements where their patient is located, so the away jurisdiction. This patchwork of rules, it's really quite a bit of a quagmire, to be frank, has led some to call for a national approach to licensure, and there are certainly advantages of that kind of an approach. One of the reasons that's often raised in support of a national license is that it could address the shortage of healthcare professionals in rural and remote jurisdictions. But some have argued that we need to be careful. We need to, proceed cautiously when thinking about a pan-Canadian license. As I will discuss shortly, virtual healthcare isn't always appropriate. It certainly has its limits. In-person visits are often what's required. And some are certainly concerned that a loosening of the licensing requirements for virtual care could result in certain professionals flocking to urban centers and exacerbating the shortages in rural and remote communities, making those in-person visits less accessible. So some important regulatory questions to think about with respect to licensure. All right, so shifting gears a bit, I'd like to look at some of the issues that arise in the clinical setting, in the context of that clinical encounter. But before I get into sort of the nitty-gritties of those areas, I do want to highlight the different avenues or legal options that are available to patients who have concerns about the care they've received. So as with in-person medical care, and as I've just mentioned, regulatory colleges maintain their jurisdiction over their members who are practicing virtual medicine. It's possible that a patient could bring a claim in tort law. There are a number of different torts that arise in the medical legal context. Perhaps most frequent we see are negligence claims. Those types of claims seek to compensate patients where the patient has suffered some harm in the context of providing or receiving healthcare. It may be that a patient could bring a claim for breach of fiduciary duty. Those types of very specialized legal obligations exist between physician and patient and requires the physician to act in the patient's best interests, and also requires the physician to maintain a duty of confidentiality vis-a-vis the patient. And then the third legal avenue might be with respect to privacy law. So there are some specialized torts that exist with respect to a breach of privacy, but there's also some statutory remedies and legal avenues under provincial legislation. So for example, in Ontario under the Personal Health Information and Protection Act. So in terms of the challenges in the context of the clinical encounter, there are a few issues that have been highlighted by, for example, the CMPA. These actually were highlighted prior to the pandemic. There are of course others, but I think this is a useful starting place for my discussion today. So perhaps most one of the things that's often talked about is the standard of care and the question of when it's appropriate for a professional to conduct a virtual appointment as opposed to seeing someone in person. It's important to note right from the outset that the physician-patient relationship that is established by a telemedicine is of the same quality as a physician-patient relationship that's established when a physician sees a patient in person. So there's no difference simply on that basis. So when is virtual healthcare appropriate? Well, there's generally a couple of considerations that are relevant. The first, of course, is whether or not a virtual appointment is in the patient's best interests. And there are a number of factors that might be relevant in determining what is in the patient's best interest. So the nature of the patient's complaint, what their existing health status is, their ability to access technology, how tech savvy they might be, what the preferences of the patient might be, okay? The second important critical consideration is really ensuring that the benefits outweigh the risks. And of course, we've seen that vary over the course of the pandemic as we've had different waves. And so when we've seen, very high COVID rates and strict public health measures, and the risk of acquiring COVID quite high, that calculation is different when we're in a situation where COVID seems to be a bit more at bay. And to refer to that letter in the fall that Will spoke about as well, from Dr. Moores and Dr. Whitmore, we do see the advice changing from the province and the college over time. So in the fall, we saw the college and the medical officer of health saying, look, it's time to see your patients in person again. The public health risk is different. So when we think about some concrete examples, virtual appointment would be certainly appropriate, for example, for a follow-up, reviewing lab results, of course, depending on the whole picture, treating a chronic condition. When might it not be appropriate? Well, obviously, if a physical examination needs to be conducted, or if a patient is experiencing emergency symptoms that require them to go to the emergency room, that they seem to be having an urgent acute situation like chest pain or shortness of breath, that would also certainly indicate an in-person appointment. Also important for healthcare providers to be ready to pivot. So if during the course of a virtual appointment, there seems to be some symptoms that requires the patient to come in person, then obviously need to pivot to ensure that there's an in-person assessment arranged. Same thing if there's a technological problem. So for example, the power goes out, something happens where you can no longer conduct that virtual appointment. Another important consideration is with respect to consent. And what type of consent is required from the patient prior to a virtual appointment or virtual encounter. Generally speaking, some of the guidance coming out of the regulatory colleges are that they're requiring those healthcare providers to obtain consent before proceeding with a virtual care appointment. That of course makes sense, good sense. And some of the things that should be discussed in the context of that consent conversation include ensuring patients understand that there could be potential increased privacy risks associated with a virtual healthcare appointment, and providing patients with some information about how best to protect their privacy. So for example, attending their appointment in a private setting where possible. Advising patients that virtual visits don't replace the need for in-person visits, that, as I've mentioned, physical examinations or emergency situations do require an in-person visit, ensuring that patients have an opportunity to ask any questions, and importantly, noting that consent on the medical record. So what about the medical record? This was something that has been highlighted by some folks about, medical records, the importance of having the medical record well documented during a virtual visit. And again, this is really critical. The purpose of a patient's medical record is really to ensure that their medical journey or their story is accurately and adequately captured. And those patient records are really critical to ensuring that healthcare professionals can communicate clearly with the patient about the care that they've received in the past, but also communicating with other members of the care team. As we know, many patients are treated by multiple providers. They could be receiving diagnostic tests in a range of different facilities. Coordinating their care might be quite complex, and having a properly documented medical record is really critical to ensuring that the overall care of the patient is of high quality. Communication is something that has also been highlighted as an area of concern in the virtual care context. And really at the heart of this is the reality that when we're doing more things online, there are different skills that may be required. So for example, that's certainly been true, for example, with me when it's come to teaching, and it's true in other contexts as well. It may be that in the virtual care environment, especially when it's maybe an initial appointment, may be more difficult for the provider to build trust with the patient, that trust that's really critical to the proper functioning of the physician-patient relationship. And so the Canadian Medical Association, for example, has put together a number of resources on how providers can work on their website manner, some of the tips and tricks to ensuring that that the communication between physician and patient really is of good quality. And then I'll just end with a very brief mention of privacy and confidentiality. The protection of confidential information is really critical to ensuring trust between the physician and patient. Ensuring those open lines of communication are critical to ensure that patients are able to disclose the information that they need to their healthcare providers to ensure that they receive appropriate care. And so ensuring that there is trust when they're providing that their confidentiality is going to be maintained, their privacy can be maintained, is very important. Virtual care can also present some new challenges in terms of the protection of patient privacy. So if we think of a virtual appointment that's taking place, for example, in a private setting, there are some things that can be done to really promote patient privacy. So having the patient be in a private setting, ensuring that if the healthcare provider is also is not in a clinical setting, that they also have are in a quiet private setting, ensuring that there is good security of virtual platforms. So if we're talking about sort of video conferencing, ensuring that there's good security and there. And then also thinking about how the data will be retained and managed over time. So I think that is my 15 minutes. I'm going to pause there and turn it over to Michael. Thanks very much.
Okay, good. I think my Zoom was hung for 1 little minute. Thank you so much, Vanessa. And we'll have our third speaker, Michael Green, and we'll have a round of discussion after that. Keep the questions coming in. It's great. We'll bring them up at the end.
Great. Well, thanks everybody, and thanks for joining us today. My name's Mike Green. I'm the head of family medicine here at Queen's, where I also practice family medicine, as they noted. I'm going to talk a little bit about some of the both the promise and also the downsides and pitfalls about virtual care that I've experienced, and that research group I've been working with has been looking at, seeing what happened here in Ontario, and a little bit also relating to some of the issues that our other panelists commented on in terms of some policy and legal issues that are important to sort out. So a couple of disclosures first. So they already introduced us all as AMS board members, but I'm also a board and executive member of the College of Family Physicians of Canada. So a couple of my slides will reflect our college's perspective on virtual care. And I'm the lead investigator for a group called Inspire Primary Healthcare that's funded by the Ontario Ministry of Health to do primary care research as a network across the province. And so glad to see Simone, one of my co-investigators, hosting the meeting here today. So from the perspective of family medicine, virtual care can be really important for helping to strengthen healthcare if it's done properly. And we have a recent position statement called Access Done Right about some of the issues related to access to primary care and family medicine generally, that includes some commentary on virtual care. And so within that, the key thing that's of importance to us is the value of continuity. In primary care, continuity of care, receiving care from the same dedicated provider over time, provides tremendous benefits to patients and to the healthcare system. And it's interesting that this evidence actually is about receiving care from the same provider. There is the evidence for providing care from the same team is not being developed in the same way, although we believe that there's additional evidence about receiving care from a team. Strong continuity is being shown to lead consistently to better health outcomes, enhance patient quality of life, and also decrease costs to the healthcare system. And there are significant concerns about the potential for virtual care to disrupt continuity of care if it's not used appropriately, and additional specific concerns about for-profit virtual care that creates another tier of private access to primary care outside of the publicly funded system. As we know, there's a limited number of people providing care, and if there's diversion of care into a privately funded system, there's often less providers to provide what's required in the public system. Just to talk about what actually happened, because I think that's a really helpful starting point to see what we have learned so far from the experience of the rapid adoption of virtual care. And I'm going to focus on work we've done in Ontario, and my co-investigators are listed here on the slide, and they're all affiliated in some way with ICES, because this work has been done primarily using administrative data about visits to doctors that are publicly funded. Will showed a similar slide. His had different numbers. I noticed on his went up to about 1.6 million per week, but that's because he wasn't looking only at primary care. What this graph shows is the normal visit pattern of both total visits, which is in the gray, blue, which is office visits, and virtual visits, which is in the red, and the little tiny green line at the bottom of home visits, which still occur, but in, as you can see, very small numbers. Over time in Ontario on a weekly basis from January 1st of 2019 through to the end of October of 2021. And the little dotted line near the top, sitting at just under 900,000 visits a week, is the average weekly visits for the period before the pandemic. And what you can see is that, first of all, if you're wondering why it's a seesaw with all these jagged saw things, all of those down turns that are the points are long weekends. And then the biggest one that you see there, that's the winter holidays. And you can see the big cratering in total visit numbers, and especially in in-person visits that happened right at the onset of the pandemic. And very quickly, the rise in the red of the emergence of virtual care up to a peak, and then gradually slowing down over time now, so that it's now actually about the same to maybe a little bit lower than the in-office visit rates. But the total visits back to baseline by about September of 2020. Now, what about continuity of care? Because this is the key thing that we're concerned about. So if you look at, no matter how you attach people to a doctor, whether they're signed up, which we call rostering by signing an agreement, or whether we attach them to a doctor by seeing who they normally see, which we call virtual rostering, you see that the blue is patients who are rostered, and the orange is ones who are virtually rostered. For total visits, you see that fairly flat continuity of care, maybe not really much of a change pre-pandemic for patients who are rostered, maybe a slow decline starting over time for patients who are virtually rostered. And then after the pandemic, you actually see an increase in the continuity of care initially, kind of returning back to the pre-pandemic baseline for patients who are rostered. But you do see this really significant decline for patients who are not signed up with a practice. And this is enough of a decline, I think, to be concerning about the continuity of care and the impact on patients who are not officially rostered with a primary care provider. When we look at breaking that down to where the changes occurred, in terms of office visits, you can see that there was a drop for both groups, but it was kind of a step drop for patients who are rostered. Probably reflects people's changing work patterns of some people going to assessment centers, maybe their colleagues covering for them in the office, more shared kind of coverage days for in-person visits. But both a drop and then a steady decline in the slope down to less than 40% for office visit continuity of care for patients who are virtually rostered. Virtual visits is really interesting. Prior to the pandemic, you actually see that there was more continuity of virtual care for virtually rostered patients. And this probably reflects specialized care that was being delivered virtually prior to the pandemic for services that are possible to deliver virtually, and very little virtual care for people who are signed up with a family physician. And then as soon as you hit the lockdown and the big seismic shift, you see all of a sudden virtual visits shoot up in terms of continuity, because now most of the virtual visits for these rostered patients are with their own doctors, not with specialists. And you see also an increase as more primary care begins to be delivered virtually, but then this steady drop off as well still for those who are virtually rostered. It's another way of looking at it. We wanted to know also, does it matter what % of virtual care you offer versus in person? So in this graph, the 0% means 100% in person, 0% virtual, and at the 100%, it was 100% virtual. And we looked at doctors and we said, for your visits, we put you into one of these categories. You know, all in person at one end, all virtual at the other, and then groups of 20% in between, from 20% or less virtual up to greater than 80% virtual. And what we found is that really the best continuity was for this middle section. If you were all virtual or all in person and not offering choice, then your continuity care was not as good as people in the middle. We think there's probably also differences just in the types of doctors here that may also influence this. For those who are offering a mix, there's a little bit of a curve, but nothing really dramatic between the groups, although these ones in the center seem more consistently at about the 70% plus mark. We then also looked at comparing rostering for those who are rostered, what the group visits look like. And what you see is that for those who are rostered, the same thing, even patients who are signed up with a physician, if their physician offered 100% in person, there's something about that practice or that setting that meant that the continuity of care was lower, both to the physician and the group. And same for if it was even more so, if it was 100% virtual. But in the in-between, there's not a huge lot of variation between whether you're 20%, 40%, 60, 80 virtual versus in person. So what do I think we can take home from this? Virtual care can actually enhance continuity of care, but this is in the context of an ongoing relationship between the provider and the patient. There was better continuity and a larger positive impact when there was formal rostering than with people who are loosely attached to a primary care provider. And continuity was lower when in person or only virtual, which was the lowest, than for a mix of visit types. I think there's some of the other issues that have been touched on in order, if we want to have virtual care, are the questions of licensure. So what Vanessa didn't mention is that there's two reasons for considering the licensure issue. One is to allow you to practice on a routine basis across provincial boundaries, but the other is to allow for fill-in or locum physicians, particularly in areas of need or rural areas. And there's a significant cost and administrative burden to the physician to get licensed in each jurisdiction they want to work. So our college has certainly been advocating for a long time for a national locum licensure. The question I think virtual care raises is whether this should be more general or only for locums. And it leads to the second question of jurisdiction. Where does virtual care happen? It's happening on some platform somewhere on a phone or in the cloud or somewhere, but is it where the provider is located? Is it where the patient is located? What's the agreement on that? And this leads back to the licensure question. If my patient's in Vancouver and they want me to provide them advice over a virtual visit, am I practicing medicine in Ontario or BC? I would not be able to send them a prescription to BC because my medical license in Ontario would not allow it to be filled at a pharmacy in BC. And then there's the question of ability to provide in-person care. What's the timeliness and ability to access that you should be able to provide if you're providing virtual care? Is it acceptable to not be able to provide it? Do you need to be able to provide it yourself or only as a part of a group? That will influence the questions about appropriateness of virtual care and who should be delivering it. And then I think there's some billing and Canada Health Act issues. For the corporate and private pay, I would think that, you know, if you're working for an online service, a Babylon or a Maple or something else like that, that's having people pay for services that are now going to be funded by public healthcare systems. You know, Ontario is moving towards normalizing virtual billing codes. When does primary virtual care become, you know, a Canada Health Act insurable service for the purpose of Health Act compliance? And the role of providers working both in the private and general system, and would that apply to same or different patients? And then finally, the reasonableness question. This really has enabled us to reach out and make contact with people much more quickly and without less of that cost to the individual of that. I liked, Will, your thing of your physical access cost of the time and actual out-of-pocket costs it takes for someone to come to an appointment. If they don't experience those for a virtual visit, there's increased pressure to have more visits and more visits sooner. And what does that do to demand for care? And what is a reasonable expectation for access? So I think those are all some of the key issues that we have to sort out. And I'm really looking forward to the discussion.
Thank you so much, Dr. Green. This was a wonderful presentation. We've had, unfortunately, my system has crashed, and so I had to log back on, and I've lost, I think, some of the questions. But I know, Colleen, there was a question. If you're able to actually put that question up to the speakers, I will see if I can't recover some of the questions that I had noted before, but that seem to have disappeared. And if yes,
they're all in the Q&A. If you can,
yeah, except that when you crash, they go away from the Q&A.
okay.
Yeah,
Okay.
but I do see some. So let me begin with Michael Wolfson's question. So that was for Mike, and I promise I'll make sure things are balanced in a moment. If the best continuity of care was about 50-50 mix of in-person and virtual care, would this reduce overall provincial primary care provider costs compared to 100% in-person care? If so, can you venture a ballpark estimate of these cost savings?
So I cannot ballpark that. I don't know that it will or not. You know, the question of strong primary care and strong continuity of care is that often primary care costs are higher. It's overall healthcare system costs that go down. So there is a question of where you invest your healthcare dollars. And that's a really interesting question. I don't know that we're going to be able to answer that until we see what happens when virtual care is embedded in the system for a while.
I would only add, Simone, that there's likely a snapback effect as well. So I don't know whether it'll be higher or lower. I don't think that reducing costs should be the initial reason to do it, but there may be a snapback that happens if you remove an access barrier. One of the things around access barriers is that they do, for better or worse, keep expenditures down by denying people needed care. And when you bring that back on, you may see costs go up temporarily. That's what we saw, for example, in cataract surgeries in 2005 and 6.
Yeah. That's great. Thank you. So from Karen Palmer, what interprovincial laws or regulation exists to prevent situation like this? At least one virtual care provider has both publicly funded hours and privately funded hours. During publicly funded hours, patients purportedly consult with a general practitioner enrolled in the same provincial plan with a billing number as where the patients are beneficiaries. Conversely, during private pay hours, patients pay a fee to consult with physicians who are not enrolled in the public plan where the patients are beneficiary, but instead are enrolled in the plan of another province or territory. This appears inconsistent with the intent of the CHA, namely care based on need, not on ability to pay.
Do you want me to start? Yeah, I was gonna say, do you want me to get the ball rolling, Simone?
I think that you'd be the perfect.
Okay.
Yes, thank
Okay,
you.
and Mike might have some thoughts as well, given his sort of closing comments about the CHA. So that's a excellent, very detailed question. Certainly, yes, that would appear to be inconsistent with what ensuring that Canadians have healthcare based on on need rather than the ability to pay. And it certainly is, from a regulatory perspective, a tough nut to crack from a regulatory perspective, because you've got someone operating in two different jurisdictions. So it really speaks to the need to ensure that different regulators are, coordinating and working together, and ensuring that providers aren't doing sort of an end run around some of the requirements that might exist. So thanks so much for that question. It's a really interesting question, and quite difficult, as I say, from a regulatory perspective. Really requires a high level of coordination between regulators. Mike might have some thoughts.
Does anyone else want
from a
to
clinical perspective
enrich that?
That was a great question. That was exactly what we're getting at. And it sounds like they're actually aware of and specifically dodging the regulations by having people work across provincial lines. So this then brings the question, though, of jurisdiction. Like, if someone's not billing and licensed to the province where public care is available, how are they able to provide virtual care in that jurisdiction without going over the issues of licensing? And maybe they choose to get a license and not bill OHIP. That'd be a minor cost. I suppose they could do that. But I think this is a bigger question that probably provinces are going to have to coordinate on. Because really my own personal view is that if Canada wanted to be serious about this, they would regulate it that if you're licensed in any Canadian jurisdiction to bill a public health plan, you can't be billing private virtual this way. That would be one potential solution to that issue.
Thanks. And maybe following up a little bit on this provincial and versus federal and in terms of legislations, but that I think was actually meant for Will. So will the need for regulation to enforce standards shift the balance between the provinces and our territories and the federal government, and how? And that is from Elise, maybe.
And Simone, let me just acknowledge first off,
absolutely.
Karen Palmer was on my team for the Health Canada work, and I'm pretty sure that was what I think you guys call that leading the witness, don't you, Vanessa, you lawyers? Anyway,
That's what we call it.
but absolutely, I mean, it's such a great point. I looked at licensure as part of the Wave 3 report, and I frankly kind of recoiled in horror, because I couldn't see, and we were trying to do a report that was practical and hard hitting at Wave 3 rather than deal with the pre-COVID structural issues. So what we said in the report, Simone, was let's apply continuity of care as the principle. And so you'll see in the report, we gave 5 or 6 really clean examples. We said, okay, a student from Ontario goes to British Columbia for school. We want to let virtual care back to their primary care doc, but that should be a billable event. Okay, a patient goes from Winnipeg to Kenora, or from Kenora to Winnipeg, more likely, to get a surgery done or to get a cardiac catheterization. Should the aftercare be provided, that is being provided virtually, be allowed to be billed? Yes, it should be, right? And so
Yeah.
there's about 6 of those really crisp, beautiful ones. I leave it, my personal judgment is that federal provincial politics are a nightmare and that I'm too old to see the solution on it. So I personally think we should go for a half a loaf solution and just and pick on stuff that's around the continuity of care question that's demonstrably better than patients. I don't think you can write a rule book fast enough. I happen to know that there are a few of these companies, guys, that have 5-person secretarial teams that just do licensure applications for doctors in all provinces. So licensure isn't going to get you there. My opinion. I'm sure the others have an opinion.
I'll give a chance to the other panelists to respond. Otherwise, I have a question for the entire panel. Okay, so let me go on. So what should the top policy choice you would make? 1 or 2 things that you could do to ensure that the shift to virtual care will result in better quality of care for patients. And by quality, you can think of the whole spectrum in terms of experience, but also in terms of the technical quality of care, which I think, Vanessa, you alluded in terms of what are the appropriate things that lend themselves to virtual care or not. So this is for all of you. Mike, do you want to start?
Well, I think I'll comment mainly on primary care first, because I think for me, the key is that the care is delivered in the context of an ongoing relationship with the team. And outside of that, I think if there's too many rules, it can interfere with being able to adapt to the right context. So I think rather than trying to regulate modalities like phone or video, or whether it's synchronous or asynchronous, that the key concept is your cares by a team, and you have a most responsible provider within that team who's quarterbacking your care.
And should we be monitoring this? Should we see whether the introduction of virtual care has caused the shift in the things that are addressed in primary care? Because there was a suggestion of that. Should we be monitoring it?
Yeah, I mean, I think the question, I think what will be really interesting for me is that question that Will raised about who are the winners and losers in the shifts in the barriers to access that occur when you shift to virtual, because we just know it just won't be the same. The people who used to be able to easily afford the opportunity costs of going to an in-person appointment may find it more difficult to access care. Some people who found that difficult may not, but on the flip side, there's the cost of access to the technology is an additional barrier. So I think it is going to be complicated, and will require some monitoring.
Yeah, thanks. Will, do you want to follow up, and then I'll go to
Sure.
Vanessa?
I mean, I was going to actually say what Mike said, so I'm going to have to say something different, but I'll build on it, okay? Because you can't figure out which electrons moving over the wire should be paid which amount. So whether it's a text, an email, an in-app message, a phone call, a video, a phone call that the provider decides to turn into a video call midway through, the idea that you can sit here and write a set of rules as if these people are picking vegetables is craziness, right? Like, you can't do that. So managing it through fee for service isn't going to work, because just to take one simple example, if you pay 3 times as much for a video call as a phone call, they'll start on phone, flip to video for 30 seconds and call it a video call. So now you'll have to write a secondary rule, right? Think of your teenager and how they're communicating, and you'll get some indication of how this is going to change in the continuous relationship, right? And that's the point that Mike keeps making, and I agree with him. I would say, Mike, that I think that there's another stream here for some patients there are in fact patients who, my son has no idea, nor should he, who his primary care physician is, because of a whole bunch of things. But there's a solid 20 or 30% out there. And you guys who talk about continuity do have to have an answer for them that isn't just, oh, well, they're not really patients. The big policy thing, because you asked it as a policy question that I will build in here, is the mid-level providers. We don't pay for mid-level providers in our public healthcare system anymore, whether they're virtual or physical.
So who do you mean by mid-level providers?
Physios for
All the other
orthopedics,
health
the
professionals.
CHF advanced
Oh, yeah.
practice nurses getting picked up on grants, a whole bunch of the mental health
Psychologists.
like I will tell you that all those ECBT programs, I don't think that's about ECBT. I think that's about CBT. I think people want CBT. You put an E in front of it and they'll go get ECBT because they want CBT, but it's not a listed service. So for me, that when we start talking, and I'm going to bring it back to what Karen was asking about and then shut up. If we're gonna talk about Canada Health Act challenges, how the hell are we going to get physios back into the orthopedics case management piece? How are we going to get advanced practice cardiac nurses in? Medley does it by putting them on research grants, but those mid-level providers got knocked out of the fee negotiations in the last 25 years.
So when you say ECBT, do you mean virtual, like electronic?
Yeah,
what is?
So we've funded cognitive behavioral therapy if it's delivered by video, or right, or I don't know if it's not even video, it's async. If it's delivered virtually.
Yeah.
But CBT in person has very limited funding available. You can't get CBT. So in the pandemic, we opened up cognitive behavioral therapy. We made it widely available. People flocked into it, whether it's good or bad. Someone who does those evaluations will tell me. My point is just, of course, people wanted cognitive behavioral therapy. They were willing to take it E, and they probably would have been just as happy to take it non-E. I should stop talking.
Oh, that's great. That's, a very important observation. We have to keep our eye on this. Vanessa, I'll go to you with the same question. So going back to what are the 1 or 2 recommendations?
So I think Mike's answer was really critical. I'm also going to build on Mike's answer and say, what I think we need to be very careful of is about patients losing access and virtual care becoming a substitute for in-person visits. I think that the pendulum swung quite rapidly to a virtual care context. And I think as the pendulum comes, back to the center, we need to be careful to hit the right balance between virtual and in person. And I think that, like those questions about standard of care and when do you see the patient and when do you have to pivot, I think that's going to be a really, really critical piece of this going forward.
Lots to learn. One question back to Will. You had mentioned, and this is, I'm going to find who said that in a second. Oh, Amy Watson. You'd talked about the benefits, so getting paid for what you do, and that would mean moving from fee for service, so you're not having to pay for all the little things and how much does this cost or that cost. How do you see that happening?
I don't see it happening. I wish that it would happen. As a former fee negotiator for the government side, I have wished it would happen for many years, and I'm not quite sure how we make it happen. I think the CHF pilots that Ontario Health is doing are smart. I think the continuous glucose monitoring that the ministry just announced is smart. I hope for more pre and post surgical bundles. I'm just processing the PSA that right now, and I'm not really prepared to comment on it in detail, other than to say that I think it looks directionally correct as a starting point. I do worry, I really worry that people are using video and virtual as synonyms. I just want to remind everyone that of virtual care was video. And for a long time, it was less than 10%. And in mature systems, it's about equal volumes of async phone and video.
Anybody else wants to comment on the fee for service?
Remember that in 10 years, there will be no distinction between how the electrons are traveling over the wire. The distinction between messaging, phone, and video is a temporary phenomenon that will not exist by the end of the decade.
Thank you. Anybody else wants to comment on the fee for service question? Okay. As a private sector players move into virtual care, is there a risk that clinicians will move from the public system into the private companies? And there was something similar about having disadvantaging certain areas as we move to virtual care and to private care, especially. Who wants to take that on? Vanessa?
So I think this also has some echoes, right, of Karen's concerns, right, about the split between public and private and who's doing what where, and there being sort of end runs around around some of the requirements. And again, I do think that this speaks to, Will's point about where the dust is going to settle in terms of ensuring that the public system is set up in such a way that allows access to the right mix of virtual and in-person care with their healthcare providers and their teams. So I think there's a lot of practical questions that need to be addressed, and certainly we can put regulatory frameworks and tools around blocking the growth of private care and that type of thing. But I think at this stage, it's really incumbent upon us to set up these systems in such a way that ensures that there's robust options in the public setting so that patients have access where required. Will and Michael might have some additional thoughts about that as well.
Well, we're already seeing that happen. I got an email in my inbox the other day from one of these private companies saying, basically, hey, are you sure you want to keep doing what you're doing? We'll pay you a guaranteed fixed minimum rate that's higher than what you make having a comprehensive family medicine practice, even in a family health team info setting, for sitting at home and answering virtual calls. So I think that is a concern. Fortunately, I think, money's one incentive and one lever. I think a lot of people go into healthcare for different reasons. It's not that the economic incentives don't matter. They are important, but they're not everything to everybody. And so, I think hopefully people are wanting to provide comprehensive primary care, whether they're a physician or there's a question from Maureen McTeer about nurses and nurse practitioners. Whether you're a nurse or a nurse practitioner or anyone else working in a team, it's more satisfying to provide that kind of comprehensive team-based care.
So let's go ahead and ask that question from Maureen. So I'll read it. You've concentrated on doctors and virtual care. The delivery of primary care, though, in many rural and distant northern communities in Canada is delivered most often by nurses and nurse practitioners. So in these changes that are envisaged and now proposed, is there a new role of greater equality for nurses and nurse practitioners? And if so, in what practical and real way? This may be a connection with the fee-for-service payment issue. Who wants to address that? What impact does it have? Is all this virtual care and the changing in the structure, what impact is it going to have on the other health professionals?
So I think we've talked about elements of this, and I'll just try to re-summarize, right? There's the question of mix of modalities, but then there's also the question of mix of skill levels. And in a properly functioning in properly functioning primary care models, you've got suitable mixes of both modalities and of skill mixes. Now, under the public system, that's often constrained in some ways that have a lot to do with the fact that the medical association leads the negotiation. That was my attempt at being polite. There's a second issue that plays out here, which is what I've started calling the talk and text issue. In spite of the federal government's claims, many people don't have, particularly in rural and remote places, as Ms. McTeer points out, do not have access directly to MDs, and they also don't have access to good video. I mean, I'm just in Orangeville, 75 kilometers north of the city, and my video has almost failed 3 times on this session, and that happens regularly. So we have to think about practical mixes that allow providers and patients to make the intelligent decisions that they will make, and those need to be in the public system, because if we keep on leaving this second tier out there that goes and does its own thing around the edges the way we are, I guarantee you we will 2-tier this system on virtual.
And I guess, so going back to what Maureen, I think, was getting at, this is an issue that has been raised for a long time. There is this notion that the healthcare system or practices are driven, the primary care provider is the central focus, and other health professionals are maybe don't have the same equality in terms of how things are structured and so on. And so, and yet these same individuals play a big role where primary care or physicians are not available. So is this context change going to impact that perceived inequality, or is it going to close the gap? Mike?
I think there's a couple of things. One, I don't think virtual care in and of itself changes any of that, power differentials between types of providers or what's funded under the Canada Health Act publicly funded services and what provinces choose to fund or not. So I think not to confuse those, but I think that virtual care could make it worse. And I'll give you a couple of examples, like right now, or it's an opportunity to change how we think about it. So right now, many primary care group offices work, a lot of primary care nurses and even primary care nurse practitioners. Some are hired directly with public funds, like through a family health team. Many are funded indirectly through physician billings, because that's our primary way that we fund primary care in most of Canada. There's exceptions. So, I mean, Maureen might know, I worked in Moose Factory for a long time with Health Canada funded NPs, and it was an APP. It was fantastic, interesting work environment, very different. But if we want to think about the general rule, that's how it's funded. And many of those are services provided under supervision as a part of a team, and that's how a practice is funded. If there's new regulations that the physician has to directly provide the digital service, that will have a negative impact on the role of funding teams through that mechanism. Right. It's maybe not the best mechanism for funding it. Maybe they should bite the bullet and fund the teams instead. But that would require much more political will and bigger changes to the system than just introducing virtual care.
I think the only thing that I would add to that is, in addition to the funding points that Will and Michael have raised, is, again, this is an age-old question about scope of practice, right? And what nurses and nurse practitioners can do. And, that doesn't change necessarily depending on virtual or in person. Again, but it does depend in part on the funding. So that from a regulatory perspective, the scope of practice is also an important thing to watch for.
Thank you. I have a question from Kathy Kastner, who is a patient partner, and so is Elise maybe, who asked the question earlier. And it's great to get that perspective. So as a patient partner on various North America-wide advanced care, advanced directive research initiatives, thoughts on video, and I'm not sure what that is, I'm sorry, THOTS, and or digital advanced directives. Maybe, yeah, maybe it was meant thoughts as in like ideas. Kathy, can I say anything else to clarify? So maybe I think the question is, how is that technology going to play a role in advanced directives? How is that going to influence how we use advanced directives in the clinical setting? And send me a text if you wanted me to say something a little different. Yeah, it was meant, yes, thoughts. So she confirms it is thoughts. So any thoughts on that? How, we talk about making sure that the diabetic care is appropriate and that there's continuity of care. What about the advanced directives? And this is very difficult discussion.
So I'll maybe give that a shot. I mean,
Yeah.
Because I see this in my practice. You can think of it in I wonder about it in two directions, and I would be curious if Kathy could put a clarification in what she meant. Like, digital tools can be helpful in the right setting for establishing goals of care and advanced directives. Particularly, I think if you can take that burden, like that, you think of the cost that Will mentioned at the beginning about an office visit, think about a family. Living all over with people in even different continents and places wanting to have a family meeting to do advanced care directive for a relative. Digital tools have an amazing ability to help overcome some of those indirect costs and let the right people be involved. But it's not always sometimes the in-person meeting is better. So I think most of my experience with those has been they're hybrid. Some people are there on the iPad or the computer, and some people are there in person, but it at least allows more people to be involved.
I would just add, and this is more as a patient than an area of expertise, or more of as a patient partner, that it does, I think, come back in part to that continuity of care point of view, right? If you've done a hospice visit and you're set up, having access digitally or virtually to those providers can be tremendously helpful, because you can get quick questions answered. You can email, and get those kinds of things done. I don't know about advanced directives, though. I mean, I'd be curious what Kathy's thinking about. Like,
well, I would wonder about it going the other way. Like, having done home visits for my patients who are, don't want CPR, don't want particular interventions, their biggest concern often is like, how will the person know? Like, the person not at my point of care know. I think about all the photocopies of triplicate forms that are like, with magnets on someone's fridge, so the ambulance doesn't try to resuscitate someone who wants not to be resuscitated. Like, I think digital tools have some great promise in that area, but they would have to be, to your point, Will, regulation, standardized, interoperable. Everybody knows where to find them. Just the same issues as with the piece of paper. If you don't know where to find the digital care plan, you also won't be able to access it.
So we have 3 minutes left. What I suggest is that we do a little bit of rapid fire questions so that we can cover as many things as possible. I've got one for Vanessa. So we often hear the comment that a pan-Canadian licensure will cause migration of providers from rural or remote areas to urban areas. Is there any evidence for this?
So
Or
there
any
isn't,
concern?
yeah, I was going to say there isn't any evidence. I know this is rapid fire, I'll be quick. There isn't any evidence that I know of, but I don't think there's any evidence going the other way. And in fact, it seems to me that we have across the country been struggling with getting providers into rural and remote settings. And so we wouldn't want to, we would want to be conscious of that and not aggravate that situation when thinking about a pan-Canadian license.
Thank you. Will, in your presentation, you made a note of a report, the Wave 3 report in April 2023. What's the significance of the date?
Oh,
That's
April
from Nicole.
April 2023 was intended to be a point certain, and there's no significance except that it's the start of the federal year or the government fiscal year. The point is that each province and territory should pick a date by which
Oh, yeah.
all prescriptions and all lab ordering and results will be done digitally. There's some weasel words in there to make it implementable, don't worry. But each province and territory needs to pick a date certain. And the date certain that I recommended was April 1st, 2023.
I see. Thank you. There's lots of praise in the comments, and I'm not going to, so, we'll share these with you to the panelists. So don't worry, these are going to be conveyed. One last quick question. Have you seen, and I can't remember now who, this is from Jennifer O'Neill. Can't remember who this was to, but have you seen any indicators looking at change, positive or negative, towards a person-centered care or communication interaction with the use of virtual care, and how is this changing in your opinion? So I know you'd mentioned that, and I think it was Vanessa who said there doesn't seem to be any patient-provider relationship is not changing in virtual care. I'm not putting words in your mouth, Vanessa.
Well, and so I think what I meant by that is that the legal requirements are no different whether you're seeing a patient virtually as opposed to whether you're seeing a patient in person. The same standards apply. Yeah. So in terms of the actual statistics, I'm not sure.
That's fine. And, maybe some of your other questions, I'm sorry, I know we've run out of time. Can I get some cues from the organizers, whether we should be wrapping up and thanking or?
Yeah. Hi, Simone. It's Colleen here. Yes, I think we should.
Okay, terrific.
Everyone has to go to Save the World.
Yeah, sorry. I think we could have been here for quite a much longer time. This was great discussion and lots of interest in this. And thank you so much for sharing your insight, your knowledge, and your enthusiasm about this. I think it's gotten us all thinking. Thank you.